And I hope, I don't know whether I'll get to it tonight. I'll surely get to it tomorrow morning. The uh, the second half of that, because I got the heart stuff out of the way, and then I'll do the blood stuff out of the way. Remember, it's a 2 chapter exam. So, and so you'll have all that information, and the exam's going to be on the 14th, which is a week from Friday. So I'm sure you'll have it tomorrow. I mean, I only had enough time this morning to get that taken care of, to get that first section taken care of before I had to run, because the flood downstairs that we had, if you didn't know about it, in that room where I usually do micro at 142, they moved us all over to Hale, and that's going to be the same thing for Friday as well. So, nevertheless, that's the jumping off point. So we begin with that. And the other thing, just because there were some questions about it, the new unit starts with the blood vessel stuff I'm going to be talking about, which I know some of you already had, and some of you will have today in lab. So I'll have sort of a generic discussion about that as we go over, hopefully, a fair amount of this first PowerPoint from Marie. And then, as you can see from, let me get back this way. We go back and look at the Unit 2 stuff, because I wanted to make sure everybody, this is all the stuff that you need. So there's the Marie PowerPoints, the heart and blood vessel outline, the cardiovascular, which have heart and blood vessels, which would apply to the heart and the blood vessel portion from Welsh Hole, etc., etc. So your resources are in place. Look at you. So I am trying to do my job with some degree of alacrity. But based on any attempts at humor in the last class, it was a total and abject failure. Allie, who I used to like, just was stoic through the entire class. She really increased my ire. I had to call her out. I just can't tolerate it. You're next.
What did I do?
Nothing. That's You don't laugh at the jokes. I made several clever puns, and they all looked at me like, clever was a stretch. Somewhat clever, not clever. It's okay. Which is why I have always wondered why these last few months when we've been going to the gym, my wife has like the skull candy thing. She likes the one. She doesn't like she likes the wired ones. Why she keeps them in the house when I'm talking. Now I know why. She doesn't. She's like you. She doesn't want to listen to me. I hope you're laughing out there in virtual land. I just want to let everybody know. So let's conclude, thankfully. The heart. This is the last part. There's not a lot to it. The whole idea is any inequality, the heart is doomed for failure. We call it congestive because when the heart is either failed or failing, it basically can't pump the blood around. And ultimately, it's a plumbing system. Bless you. Okay, it goes backwards. So effectively, like in this, if the left side of your heart, let's say, is starting to fail, then it's inadequately pumping blood out of the left side. So it backs up to the lungs. We call that pulmonary congestion. And what happens, the fluid seeps out into the lungs, and now you've created a big problem. Now you have fluid that's congesting the lungs, so that the right side of the heart has to push extra hard to try to get its blood into the lungs. Moreover, the congestion will not permit the exchange. Okay, and so at that point, the left side's still saying, "Oh my God, I'm not getting the message. I'm not getting enough oxygen to the tissues or to the heart itself." The right side tries to pump harder. The left side is unable to get enough oxygen to really generate its own supply, and inevitably both sides fail. And you can paint the same scenario for right side. If the right side starts to fail, what happens? It backs up, except it's not backing up into the lungs. Think gravity. The right side of the heart, basically, the blood can't get in. Now, the blood coming from the head and the neck area by the superior vena cava, that can get in with gravity's help. But where's it go? Abdomen and lower extremity. We call that peripheral edema. Blood seeps out, goes into water, fluid slips out, goes into the tissues. Right? It congests them. It's a different type of congestion that's there. And now effectively the left side of the heart is pumping against this congestion, it begins to weaken because there's an abundance of fluid in all the capillary beds we're going to start looking at today that it's going into. So now it starts to fail. So one-sided failure, any inequality, both sides. So you're going to learn that. A name I put up there for right-sided failure. Why I put it up for you folks in nursing, it's one of those pet names that the nurses love to use. Years ago, they did this. I've been teaching nurses and getting ready for NCLEX for 25 plus years. It's called core, which means heart. Pulmonale means the lungs. So it's not a heart-lung per se. It's the condition that is another name for right heart failure because of congestion in the lungs and the right heart fails. So one of those little impressive. Yes, what happens when the right heart failure, what's it called? If one of you comes up quickly with core pulmonale, they're going to think, boy, you know your stuff. Don't tell them I tell them. Okay? See, I'm trying to help you. Good enough. What causes it? There's so many things. We think about, our context is the heart, but it isn't just the heart. Okay, a lot of things weaken the heart. I mean, there can be problem with peripheral vessels, vessels that are constricted elsewhere. It can have to do with excesses in diet, lack of exercise, genetic factors. There's a lot of problems. But whatever that is that led to this, the word athero means fatty. We used to call it arteriosclerosis, but to be anatomically and physiologically accurate, it's a fatty plaque that forms. It forms in that layer under the lining, under the endothelium. That's where there's some loose connective tissue, that's collagen. That becomes inflamed. When it becomes inflamed, it creates these irregularities where fatty materials can accumulate that are circulating. And they target those areas, not just in the end, the coronary arterioles, but everywhere else. So when we see it in the coronary, trust me, you're going to see it in the kidney, you're going to see it in peripheral tissues. It's just the way it works. What's happening in one artery, remember we looked at the eye, and you could look at the eye grounds. When you can look at the retina, you saw those blood vessels we talked about. It's happening there. It's happening in the heart. It's happening in the coronary arteries. It's happening in the kidney. That's a very significant sign of internal damage about to come. When we talk about high blood pressure, that's the enlarged heart. Again, and this is the chapter where we discuss it. The bottom number of your diastolic blood pressure is resting tension, sympathetic tone, we call it, in your blood vessels. If it's high, the heart has to push again. It can't expand them. It can't get past that muscular nature, the elastic nature, particularly those elastic arteries we talked about. You're going to see here, and I'm sure Dr. Robbins is going to talk about today for you folks that didn't have lab yesterday. Okay? And it may help the heart initially to work harder, but there's a law of diminishing returns. Eventually, that heart becomes so muscular it can't expand and contract efficiently to move blood around. And so it's going to cause the weakness in the myocardium. You could have previous heart attacks. Cardiomyopathies could be like an autoimmune disease. They could be from certain types of drugs that have been associated with this over the years. They can be genetically based. They can be viral in orientation. And the big problem with them is you don't have a lot of ways to go. It's not like you can, well, my heart's overweight, it can go on a diet. I don't mean to be flip about it, because those people are going to be looking at heart transplants. And heart transplants do not have a great deal of, they do not have long-term success. I mean, I don't even know what the statistics are. Years ago, you were looking at 5 years of survival. You're prolonging somebody's life. I think they've certainly improved over years today, and certainly they're working on semi-mechanical hearts and artificial hearts that down the road. And one of the things they do in trying to do with stem cell research is to try to grow these organs, whatever your feeling is about that. Those are events that are going on in the future. And some of the things that we think about, you read about them in science fiction and things like that, but the reality is that's kind of where we get this stuff. So just what I wanted to do that. So pulmonary congestion, this was pulmonary edema or peripheral edema, left side and right side. Another term we use is decompensation, and there's lots of ways to treat it, but ultimately you have to find out where the problem lies to be able to treat it. And that basically concludes the material on the exam we're having a week from Friday. Voila. Second half of the study guide, the recorded study guide, coming to you hopefully no later than tomorrow sometime, whenever I get ambitious. I know a half dozen of you will email and say, where is it? It's okay. That's why they pay me. Voila. So I'm using the Marie ones because you have the other one already on board. I'm used to this. And I don't know how much of it is going to overlap for those of you who didn't have lab, but I'm going to try to go through relatively rapidly because it's going to be, I have to give you the idea of what these blood vessels are. Because we talked at length already with that dicrotic notch, the elastic artery, right? How important it was. So here we go. So effectively, arteries blood away from the heart, veins back towards it, the exceptions, pulmonary and umbilical. The only place where exchange takes place and the only vessels that really come in direct contact are the capillaries. There's two exceptions where we don't have quote unquote direct contact. You remember the blood-brain barrier from AP1? If not, go back and look at it. Those are capillaries that have a lot of tight junctions and they're surrounded by glial cells known as astrocytes. That provides what we call the blood-brain barrier. It's only things that can pass through those membranes. It's very specific. We have to tailor medications to those and various products that we use to those particular things. There's one other area that does not occur in the female, but in the male. And the male, that's the testicular area. Okay, because sperm cells, we go over this in repro. Okay, sperm cells are produced at puberty. They're not there at birth. So if they would get in contact with the general circulation, where the general circulation capillaries were exposed to it, white blood cells would attack it. And that is a problem that sometimes we see in traumatic events and tumors and ruptured blood vessels and really significant damage to the testicular area, usually resulting in the need to remove one, if not both, of the testicles. So imagine it can be pretty severe. So, I mean, that's just a little piece. We review that in repro. What's interesting about this, it's a closed system. I don't know why they have these little maybe they ran out of ink. I just think they're showing you they get smaller and smaller. That's what they're talking about. Okay, but really it's a closed system in that it starts in the arteries, it works its way down as they get smaller to arterioles, smaller, 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 and eventually leading into capillary beds. Then those lead into venules, then into veins. Veins get larger, 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 and on we go back. Closed system, closed circuit. The lymphatics, which we deal with in the next chapter, which are part of the immune system. They're sort of the, if you want to think of it, the specialized circulation of the immune system. They are open. These are open-ended here. They pick up, if you did not know, products in the tissues that are too big effectively to fit in capillaries. They would clog them. So you're looking at particularly fatty-laden compounds or big, heavy proteins. Also invaders, like viruses and bacteria, various kinds of elements like that are carried by way of the lymph. And what happens, there's little way stations along the way to sort of sift through the lymph, okay, filter the lymph, and that's where it's attacked. We call them lymph nodes. When they're inflamed, you have a name for them, we call them swollen glands. We will get to this when we talk about and that's a one-period lecture to go over the anatomy. It's a very unanatomical system. Its physiological mate is the immune system. The bulk of our third exam is the immune system. And typically, as well get you up to speed here, the hardest unit we do, AP2. I said it's the last class. It's unfair to me not to tell it to you. Because of what was going on, not just my daughter's wedding, but because of what was going on with my wife's and her mom. We knew we were getting close. I felt it was the time, effectively, forgive me, I threw you a freebie in that first exam. I designed it and made it open book so you guys could all get a good grade. And thankfully, most of you did. That's it, people. School's out. It starts now. No, oh, what can I do for extra credit? There is none. Remember that. So these next 3 exams, 2, 3 in the final, it is what it is. We're taking them here. They're not open book. They're not online. So I said the same. I wouldn't tell one class and not the other class because I like you better. Believe me, after today, I like you better. Just blame Allie. Don't start. It could be you. I'm being very sincere. Get busy on this. So much for the warning. So, vessels, the lumen is the term we give to the opening. So we talk about that. Okay. Vessels, except for capillaries, have 3 layers. The layers are important. I know you probably went over some of this stuff. The internal lining is called the intima. Okay, it's simple squamous epithelia. It's continuous with the endothelium of the interior of the heart. It's the same stuff. It covers the valves. It's nice and smooth. I do this 6,000 times. I'm sure I'll keep doing it. Boom. So it's nice and smooth. Blood's going to go over it without turbulence. That's the whole idea of that kind of a lining, period. Anything that makes it irregular, like the aforementioned atherosclerotic plaques, they make little humps and bumps. And what happens, what causes that disease, it stops the blood from flowing. Sometimes creates clots, and then sometimes the clots lead to things like heart attacks and strokes or other problems that are there. So you have the intima. The media is the middle layer. What happens in the media is that in arteries, it is the more muscular layer. Okay. In veins, the large, thickest of all those layers is the externa layer, because veins are designed to stretch and hold the vast majority of the blood. You were going to see a slide. It's terribly important. At any point in time, 2/3 approximately of your blood is in veins. We go nuts about arteries and give short shift to veins. I did research in veins. I gave presentations on veins. Whenever you have one of your instructors, professors, whatever they call themselves, I'm not a professor, that's academic rank. Title is doctor. I don't go crazy when somebody calls me Professor Stein. I take the compliment. Okay, but the reality is, anytime you get somebody who's spent a lot of their career looking into these things, researching, writing, talking about them, you tend to get more questions than from somebody else. That's part of it. That's how you out-psych the teacher. Go in and look what their research is in. When they get to that topic, ears up. Trust me, I'm like that. Trying to make your lives a little easier, not harder. I know my exams are a pain in the ass. They're designed. Grace, would you agree? See, at least you smile. I give up. Here we go. So, intima for intimate contact works for me. Slick works for me. Little bit of basement membrane is found. Okay, and then only in vessels that are larger. About anything under about a 0.5 millimeter, we can't see with the naked eye. That's about the time they get to be microscopic. It's almost a definition when we use that diminutive suffix like arterial or venule. At that point, they go from arteries to arterioles or from veins to venules. The middle layer, smooth muscle, and you're going to see in the arteries, elastic sheets. Because of that, they have nerve fibers that go in and they control whether they narrow or widen. This is the big layer in arteries, and because of that, it controls blood flow. If nothing else, this chapter is about how we redirect blood flow to areas of need, just like we talked about in fight or flight. It goes to the heart and it goes to skeletal muscle. We dilate those vessels. In the meantime, we constrict genitourinary and gastrointestinal blood supply. We don't need it. 1/4 of your blood supply at rest goes to your kidneys. When you're active, it's not helpful for you at all. That whole thing, when your mom told you don't go swimming or don't go in the ocean because you'll get cramps, okay? They weren't, until a half an hour after you ate. The reason they tell you that, and it's accurate, it has nothing to do with abdominal cramps. But depending on what you eat, that's a different story. It's because you're at that point, the blood supply, the majority is going to your digestive and genital urinary areas. And you go out and do vigorous physical activity, your body can't compensate quickly enough. And what happens, the cramps you get are in your legs and in your arms. And I mean, if you get caught in a riptide or something, you could die. You know, I'll tell you what the waves were like. We barely got into the ocean. The Gulf at that point. We barely got into that because the waves were intense. So just saying, and the externa, this is thicker again in veins. Some people call it the adventitia. Formally, I mean, if you want to be specific, adventitia are blood vessels that are adherent or anchored. Whereas if they're covered by something called serosa, which is not that common, they slide around. So most named blood vessels are anchored, and that they use the term adventitious. That's a fine point. Don't go there. Okay, and the bigger veins have elastic fibers because they stretch. Veins are capacitance vessels. They're designed to widen when we need to. All that blood flows into. You can demonstrate on yourself easy. All you have to do, just like you do when you're taking out blood or you're starting an IV, just occlude it, put your wrist over it, your hand over it, start pumping like they tell you to do. And your veins will dilate. You'll be able to see this. You can see mine if you're up close. Okay, easy to get. I have great veins. Be able to get. That's because they expand. So it's useful for that. There can be problems such as varicose veins or vein damage when they expand when they shouldn't or excessively, and they lose some of the compensatory ways of dealing with that, which we'll get to down the road. Again, large vessels need a blood supply. We call them vasa vasorum, vessels feeding vessels. Okay, very tiny blood vessels, only in the larger vessels. They nourish it. It's not a big deal for us. This is, I mean, if you remember the dissection that you did of the heart, okay, that's an elastic artery. That would be the aorta, the pulmonary trunk, carotid, subclavian. Okay, that's the elastic nature of it. And how you knew they were arteries, they held their shape much better than veins, which are hard to find because they swoosh down. And that's veins just don't have nearly as much elastic tissue. They're just different. And even you remember the difference in the openings. The carotid canal, very much circular, carotid artery. The jugular foramen, irregular in shape. See, that's how we put this together. Love that. Great slide. Number one, capillaries. Nothing. All they are lining cells. There's no muscle. There may be some basement membrane, which is just a sheet of protein. There's no smooth muscle. There's no elastic fibers. There's no extra nerves. There's no outer layer. It's just that. It's designed for one thing. Let's exchange. Again, that's all right. We have sneeze twice. I'm good with that. You should see me yesterday coming back from the gym. He was great just when I ramped it up. It was Katy Perry. Just did great. My wife's wondering what I'm doing. She usually starts next to me, and then she goes, other way. Okay, but these are designed for stuff to pass through them. Oxygen, carbon dioxide, it's easy to get through because they go through the membrane, but little clefts, nutrients and waste products were the exceptions I noted. Look at some of the major differences that are here. We an abundance of elasticity in the intima, in the artery. You have you have the standard lining and a layer underneath it. You have elasticity here. When you get to the media, you have additional elasticity here. It's quite thick as compared to veins. Okay, that's a big difference. You don't see any elasticity. Only in large veins do we see elasticity. They don't even depict it here. Veins have those flaps. That's what I drew up there. So these are called valves. They're not in every vein. They're principally in the extremities and they're very much cup-like, just like the valves we saw and talked about in the heart. What happens? They're open this way when you and I are walking because we're moving our arms as we walk around. There's a pumping action from the muscles, and basically it's pushing the blood back toward the heart. So the orientation of the valves allows the opening to go this way. What happens when we stop, those valves, assuming that there's nothing wrong with them, will come. They're not enough to make a sound. They're not, but they close, and basically, theoretically, I mean, if I can move the blood, I take a long walk, and the blood's already up here. If I stop without the valves, boom, go back down to my feet. So we call it the column of blood, and the valves ensure that. When people have faulty valves, you have things like varicose veins. You have the potential for forming blood clots. It's a significant, very significant area. So I researched and trained with a couple of doctors who know a tremendous amount about that, and I credited them when I gave a paper and did another paper at a symposium about these things. These many years ago. I haven't done that in, oh my goodness, the better part of 50 years. They wouldn't even know who I was. I was that big now from 50 years ago. Just saying. And so you can see it, the externa collagen fibers, but look, thicker in the veins, disproportionately so to the arteries, thicker in the arteries in the muscle layer, disproportionately so to the veins. This is, well, look, this gives you an idea. Lining is lining, it doesn't change. Elastic tissue increases, obviously, in elastic arteries, the ones with the rebound. You can see the relationship, there's always more muscular than elastic, significantly so here. And then you have the outer lining. But the big deal here, arterioles, as you will see, we can't see them, but comparatively speaking, look at the lumen, the opening here. Very, very large compared to the overall diameter of the vessel. What that means is those muscles that surround it on the exterior, they can close it off. And that's exactly what happens. They can squeeze it shut, or they can limit the flow. We control blood flow to vital structures, principally in arterioles, maybe in some of these smaller muscular arteries. Those, you always have an opening. In these, you can close it off completely. So you can actually redirect blood flow, and as you will see, bypass capillary beds that don't require it. The body's very good. When we need oxygen and nutrients, we send it there. If we don't need it, we send it somewhere else. These are little things you don't have to say, oh, by the way, I think I'm going to use my foot a lot. You better send extra stuff down there. You don't have to do that. You can't do that. I mean, those are part of your, if you will, your precepts that are there. Again, give credit. Let my team not suck tomorrow. It's been a very hard year if you're a Manchester United fan. Very hard. Difficult. The only one, those are two teams I go nuts for. The Steelers, you know how that ended, and Manchester United. And it looks like it's ending in the same way. I don't listen to sports shows on the radio. No, there's problems. Capillaries, or as our British friends say, capillaries, are just that. They only are lining. Maybe there's a little bit of protein. You're going to see there's different types of capillaries for different areas, and that's an important distinction. Veins, again, really, they just have a scant amount of muscular tissue, and even the larger veins, comparatively speaking, but always proportionally, there's more exterior, as you can see. And the only time in the very large veins where we have elasticity that are there to allow them to expand. And again, the term that we use consistently, capacitance vessels. So this divides them. These are the ones we talked about. They're found, elastic is found in all three tunics. They have a lot of smooth muscle, but they don't constrict. They're designed to be open and to stay open even if they're stretched and rebound. As we talked about, the whole idea, the major ones, the aorta, the pulmonary arteries and pulmonary trunk, carotids, subclavian. Those are the big players. Okay, pressure reservoirs, expand and recoil to the continuous blood flow. Just what we talked about. That explained it better than I did. Okay, because it's not like the blood stopped in between heartbeats. I wish I had thought of it. Okay, these are any of those. If you have it has a name other than the ones I've told you, it's a distributing artery. So all the muscular arteries, and they deliver blood, whether they're the liver, hepatic, gastric to the stomach, splenic to the spleen, pick a name. Radial, because this is along the radius, ulnar, on the other side, femoral, posterior tibial, you'll see all of these. And they're not much more than you think. A large one, take the radial. That's certainly not pinky size. That's more like a little bit larger than a pencil lead. That would be like, that's, the pen or pencil you might be using is probably has a greater diameter than that vessel. So most of the named arteries, their media is thickest, there's still elasticity, they can vasoconstrict, and the arterioles for sure. They really control blood flow into the capillary beds, constricting and dilating, and they are the resistance arteries because their diameters will change in resistance to blood flow. Our blood pressure is most controlled there than anywhere else. As you will see subsequently, it's not on this PowerPoint sequence. It'll be on the one we look at on Friday. So you will see it there. And so when we get to the capillaries, dear, think how narrow that is. A red blood cell is about, 7 angstroms. Very tiny. We're talking in micrometers. Okay, tiny. Okay, yet they can get through one at a time. Sometimes they're so narrow, not only have to go single file, sometimes they have to actually bend. So it's sort of like, in the old days when you had your coins, you don't use those machines, you put them into the wrappers. Sometimes you have to start when you put them at an angle, and then they flatten out, you can put them in. Kind of like that. Coin wrappers. Change, we used to use that a lot. Stranger in a strange way. And so what they have are, some of them will have these exterior cells called pericytes, and they will control permeability. They're not all open and permeable, and they can actually become a little more or a little less permeable, as you will see. Where we do not have, these are supplied by diffusion. We mentioned this in AP1. Cartilage is avascular. Epithelia have a wonderful blood supply, but not directly. It comes from the loose areolar connective tissue underneath it, the cornea and the lens. Okay, when you dissected the eye, they weren't transparent. They were okay. They were opaque. You couldn't see through them, right? That's because the amount of their ability to get oxygenated and continuously keep that clear just magically disappeared. Eyes start to cloud over. They do so with aging and things like that as well. And so the capillaries, there are 3 basic types. And basically they have tight junctions, that's watertight, and clefts. Depending on the amount of tight junctions and the nature of the clefts kind of controls what can come through and what can't. So most of them are called continuous. It's kind of like this. I've been doing this forever. When you were a little kid, sometimes all you had was a spigot someplace at a playground, if you're lucky, or outside of your house, and you just cup your hands and get water and you do it like that. Half the time the water won't come through because even though it looks like it's watertight, it's not. You have little openings. So if you have an abundance of tight junctions, you make it completely watertight. Again, we only see that in the brain and in the male in the testicular area. Other than that, they're mostly continuous capillaries, nearly everywhere. Okay, and that whether they're going into your skin, whether they're heading toward a particular organ, for the most part, they're like that. Your heart would be like that. The capillaries that are around the heart. Okay, normal. What happens? There are ones that have wider openings, bigger clefts, less tight junctions, and very often they have. And so this is the continuous one. You can see where it is. Okay, these pericytes will open and close the clefts frequently to either accentuate flow or to limit flow, so to speak. Skin, muscles, lungs, central nervous system, with the exception of the blood-brain barrier. Okay, and so these parasites outside, peri means around, control the clefts. Fenestrations we see where hormones are produced in the endocrine system. We see them where absorption is in the intestines, but boy, we see them more than any place else in the kidney, because the openings are big enough to let plasma go through, but they're not so big to let proteins or formed elements, red cells, white cells, and platelets, get through. And they even have parasites to control that, to increase flow or decrease flow, to help control our blood pressure when we get to that unit. So they look like this. Fenestration means a window. In surgery, like so you're working on a knee or an elbow, you use what's called a fenestrated drape. It'll be a sterile drape. You'll open up and have a hole in it. You put it around where you're going to work, clamp it on either side with a towel clamp, and voila, you have a nice field around that area that you're going to work on. Use them all the time. So fenestration just means a window. Okay, increased permeability. In this case, they are kind of Swiss cheese like. I personally prefer Gruyere, but that's me. It's too expensive. No Gruyere fans. That's Swiss cheese on steroids. That's that's decadent. And you can see the little fenestrations that are there, and we can control them as well. But they're designed because, as you'll learn down the road, the kidneys work as a filter more than anything else to start. And so we see that. And then lastly, we begin to see sinusoidal. That's the liver. That's the spleen. That's the bone marrow. That's big areas. It's designed now to allow cells get through, larger elements to get through. The liver is processing all the blood in a special blood system called the portal system, 2 capillary beds in sequence, going from what you've digested. So it's filled with stuff that has to be processed. There's toxins, there's potentially invaders. Those are big. So it's designed, and it kind of sort of oozes its way through. So I use the term percolates it through, which is the way we used to make coffee before everybody sort of forever have drip makers. So they have large lumens, liver, bone marrow, spleen, even the adrenal gland. Very sluggish. It allows lots of time for it to pass. And inevitably, there's lots of white blood cells, because these are areas where invaders, particularly the liver, and to a lesser extent the spleen. The spleen is one of the organs that plays a role in blood, and it plays a significant role in the immune system as well. There it is. You can see those large openings. That's why we call it that way. Large clefts, etc., that are there. And capillary beds are just that. They are capillaries. They basically call it the microcirculation. Typically, they go between an arterial, a tiny artery, and a venial. Okay. Typically, there's one artery that ends in called the terminal arteriole, and there's a venial that collects all the blood from the capillary bed called the postcapillary venial. So I have the terminal arterial and postcapillary venial, and in the capillaries, gases, nutrients, waste, da 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 da. So that's where the exchange takes place. Again, we can distribute them as necessary. So that terminal arterial, and again, arterial is feeding into that area, and it's based on, if there's a lot of waste product, if there's lactic acid, it's going to open the door. If there's a lot of metabolic waste from activity, particularly when we're associated with muscle and joint activity, it's going to go there. If there's not, then it's not. It's going to redirect it to where it's needed. So when they say vasomotor, those are the nerves. When they say motor, it affects the muscle, in this case, the smooth muscle, either constricting it, widening or dilating it, and sometimes actually closing it if necessary. So again, when it's needed as opposed to not. And when it directs it someplace else, we have a great name for it. We call shunting. A lot of times when we have to redirect blood flow because of a clogged vessel, there's a surgical procedure where we introduce a shunt, a bypass. And so this is what kind of it looks like. Capillary bed being fed, feeding into that postcapillary venial and then to another venial versus not. Whereas, and so there's a lot of these. These are shunts connecting the arterial. So they really are designed to bypass it. And you see they are called meta-arterioles. They're sort of beyond, and they have a channel that will bypass the capillary bed. You'll see that in a second. And what controls the blood is, again, local chemical conditions, and they have a sphincter. A sphincter is a circular piece of muscle that controls flow from this special arteriole called a meta-arteriole into the bed. So these are the precapillary sphincters, these guys. And basically, if this is a bed that's not being used at all, basically it's a thoroughfare channel. So we're just shunting it through here to here without doing all the exchange. So that blood really has maintained its oxygen supply and maybe being used someplace else, or just going back to the heart starting over. And again, if I go back and show you one that's filled, then basically these would be unclenched, they would be widened, and it would just do like any other capillary. There's a lot of different controls, mostly based on things like lactic acid would increase protons, waste products would be electrolytes. Think of some of the things we talked about would cause muscles to cramp up. And so veins, again, they unite. Veins are a little bit different. Okay? You have multiple feeders into veins. So even though you have a lot of these venules, for instance, and it services your skin. Okay, you have two big veins that everything from here and here feed into. You have veins deep inside that service the muscles. These service mostly the skin. If you hold your hand like this, the big vessels, we use them a lot for IVs, are called cephalic, because if you do this, it's towards your head, and basilic, because it's toward the base of your body. And so they're veins. So all of the veins here, this whole network, a whole bunch of tributaries, and a whole arch can go in one of two directions. They can go towards the cephalic or towards the. I can't even tell you how many IVs I've had in me that have been right there. Most recently, I went in for an endoscopy, and they gave me this. Thank you. They gave me this sedating stuff. It's like I was back in college. If only I had it lasted. I'm terrible. The statute of limitations has expired. They can't get me for all those drug usage things. I'm telling it's true. Right there. Okay. So that's why it's important anatomically to learn about them, because many of you are going to start IV. Some of you will be on an IV team. You never can tell. Somebody who you might think is all fingers is a good stick. That was me. I'm not terribly coordinated mechanically or motor-wise, but boy, they have me doing all the bloods. So essentially, that's it. So they converge and their capacitance, and this is so telling. It's a great slide. We're hardening of the arteries. Only 15% of the blood. I know if it doesn't get there, it's going to lead to death of tissue. It's going to lead to a myocardial infarction. It's going to lead to a stroke. In the pulmonary, 12%. In the heart, 8%. In the capillaries, 5%. That leaves the better part of 2/3 of your blood in veins and venules. So we need to pay attention, because that venous return is critical for all these other systems to work. That's why it's so important. You have valves for backflow. Sinuses, you learned about one, the coronary sinus. It's a flattened area of vein that collects blood. In the brain, you have what are called dural sinuses. They're underneath the dura. You'll probably look at that a little bit in the unit where you name the blood vessels. Okay. And lastly, where blood clots that cause pulmonary emboli, okay, blood clots going to the lung that could make somebody critically ill or die suddenly, are here. This big muscle is called the soleus, that's underneath the gastrocnemius. Those soleal sinusoids are where blood clots take their place. And they keep flowing up because the veins keep getting wider, and the next place they narrow. That's why we use, when somebody has to be in bed for a long period of time, those intermittent squeezers, intermittent compression devices. You become acquainted with those. That's why, whether it's me or anybody else, when you have a big surgery, to avoid keeping you in bed, they get you as much as possible up in the chair, at least. Even a little old lady with a new hip, up in bed in a chair that day, down to physical therapy, walker, working on it. Next day, probably discharge that day once they get comfortable. Get them moving, because that's what prevents blood clots. And again, all of those things are true. You see that illustration, you see that. Varicose, there's a lot of reasons. We'll get into that a little bit more with valves and valve problems. Okay, and that's a lot of people. 1 out of 6, 1 out of 7 have some amount of varicosities, and it can be very unpleasant. And so, where do we see that? I mean, you can have that even hemorrhoids can be that. They're more common than you think. A lot of these things, obesity, people would think of. There's a lot of heredity, very common in pregnancy, and very unpleasant in pregnancy. And collateral channels, yeah, well, we talked about that. Don't need that. We're done. Thank you.
Can you post that slideshow?
I will do. I did.
No, this is 18. It was only 17B.
Oh no, but here's unit 3, my dear. Aha, new unit. Hey, I got you covered here. I'll show you.